This is the last chapter of Unit 7. This is concepts of infusion therapy. So we're going to talk about things that we infuse into the body. Our priority concepts in this chapter are fluid and electrolyte balance and tissue integrity, which of course would go along, both of those would go along with infusing things into the body. And what is infusion therapy? It's when we give medications or fluids by parenteral route. And IV therapy is the most common route, and IV therapy is the most common invasive therapy administered to hospitalized patients. They usually, just about everybody has an IV. Sometimes you will have a specialized infusion team. A lot of our smaller facilities don't have these, but the larger facilities might. And these are specially trained nurses that maintains and initiates, starts infusion therapies. They say that having these kinds of teams promote cost saving. It increases patient satisfaction because anytime you have somebody that's specialized in a certain thing, they're going to do it well. And it also helps with patient outcomes. So what do those infusion nurses do? They develop policy and procedures related to the infusion therapy in the facility where they work. They're going to insert and maintain all types of peripheral, midline, and sometimes even central venous catheters, and sometimes subcutaneous and intraosseous access. And of course, intraosseous would be directly into the bone. They're going to monitor outcomes, patient outcomes of the infusion therapy. They're going to be responsible for educating the staff, the patients, and the families about infusion therapy. And they're also there for consult. If there's a need for a certain product and the doctor's trying to choose between product A and product B, the infusion specialist can help with that. They're going to provide therapies such as blood withdrawal, therapeutic phlebotomy, hypodermoclasis. I'm going to have to look that one up. I don't know what that is. And intraosseous infusions, like we talked about, and administration of medication. Okay, so I'll look that up right quick. That hypodermoclasis is just a subcutaneous injection of fluid instead of in the vein. And it can be isotonic or hypotonic, and it's to supply a continuous and large amount of fluid and electrolytes and nutrients. The difference between hypodermoclasis and IV infusion, so there are several types of infusion where a slow rate of fluid uptake is required, solutions, and that also compared to IV infusion. Typically, it's limited to 1 milliliter per minute. Blood and blood components, although it is possible to increase this by using two sites simultaneously. The chief advantage of hypodermoclasis over IV infusion is that it's cheap. So we've talked about before the normal osmolarity of adults, 270 to 300 milliosmoles if you give per liter isotonic is the normal osmolarity for adults. Water doesn't move into or out of the body cells, or whatever everything just stays put. Falls risk, though, is that you can overload the patient, especially older adults. If it's greater than 3 hypertonic solutions, this corrects fluid, electrolyte, and acid-base imbalances. And it does that by moving water out of body cells into the bloodstream. TPN is an example, or parenteral nutrition is an example of a hypertonic solution. And remember, the hypertonic solutions are going to be greater than 300 milliosmoles per liter. in their osmolarity. Hypotonic solutions moves waters into the cells and makes them expand. Okay? And so what's an example of a hypotonic solution? An example of a hypotonic solution would be like half normal saline. So an example of when you would give this would be like a patient that has cellular dehydration. So when a patient maybe, let's see, maybe a diabetic ketoacidosis patient, the intracellular space becomes dehydrated. So when you administer a hypotonic solution, that helps to rehydrate the cells. So if osmolarity is greater than 600 milliosmoles per liter, that's a major deal there because that's way off of our 270 to 300 limit for isotonic solutions, isn't it? So these types of solutions are best infused into central circulation or into a central line where greater blood flow in there provides hemodilution so that these hypertonic solutions won't cause any injury. TPN has an osmolarity of greater than 1400, so it really should always be put in a central line. It should never be infused into peripheral circulation. It can damage those blood cells and the endothelial lining of the vein. So TPN, transparental nutrition, has to go into a central line. So what kind of blood products can we infuse and think about? We're going to have packed red blood cells. And you know, usually whenever you see a blood being infused, a blood transfusion, that's usually what they're getting, packed red blood cells. You can also give platelets, fresh frozen plasma, albumin, which is a protein that normally abides in the blood, several other specific clotting factors we can give. When we're administering IV medications, of course, one of the main things we want to take into consideration is medication safety. Safety is always up there when we're thinking about what we need to do for our patients. We want to see how rapidly can we give this medication safely so that we can have a therapeutic effect for the patient. Never ever assume that giving a medication IV is the same as giving that drug by other routes. And of course, that seems like a dumb moment, but sometimes we do forget. And IV administration puts that drug into the system immediately, and they're prone to have an immediate reaction. So also understand that IV infusions have to be prescribed, and there are certain things we can do to help our physicians to make sure that our patients stay safe. And sometimes we have to remind them, hey, I can't give that much potassium in an hour, you know, because it's unsafe for the patient. I can only give 10 milliequivalents per hour. I know that they need 40 total, but I can't give it in 1 hour. You most likely won't come across that kind of thing, but occasionally you will find something that's a safety problem that you need to address when the physicians are prescribing infusion therapy. So vascular access devices, There are just all kinds of ways that we can get our medications and fluids into the vascular space of our patients, okay? There are little short peripheral catheters. That's our normal IVs that we start. There are midline catheters, and these are a little bit longer catheter length. There are PICC lines. That's a peripheral inserted central catheter. And note the word central. The PICC lines are central lines. You've got to keep that in mind. PICC lines are central lines. We've got non-tunneled percutaneous central venous catheters, or CVC catheters. You've got tunneled catheters, you've got ports, and we've got hemodialysis catheters. So as an RN, you will, in your lifetime, probably access, if you work in acute care especially, all of these type catheters. The only one that I can think of that I haven't accessed is a dialysis catheter. And my facility, we did do bedside dialysis in the intensive care unit, and so I've seen it accessed several times, but I've never actually done it myself. So peripheral IV therapies, these are just our regular little angiocaps that we use. It's a short peripheral catheter, and it's for those superficial veins of the dorsal surface of the hand and the forearm. They're usually only good for 72 to 96 hours, and then they should be removed and reinserted into another site. And sometimes you can use those portable vein transilluminators, if you have it available, to find your veins. And they are kind of neat. We did have one at Minden that I use sometimes, but really it was just to get a general idea of where a vein might be, especially if I had an obese patient. But normally feel was better for me. It was hard. It was a little bit hard for me to use those transilluminators, but they are good for some people. Some people really love them, and they are handy to have around when you just cannot find anything. So remember, veins cannot be used in patients on the side of a mastectomy. You should not be using any veins on that side. If they've had axillary lymph node dissection on that side, you shouldn't use it. If they have lymphedema, if they have paralysis of that upper extremity, and also if they already have a dialysis graft or fistula on that side, you should not be using the veins in that arm. Infection control. The CDC, of course, recommends aseptic preparation and technique when inserting any kind of vascular access device. And this will include your hand hygiene. You're going to put on your gloves. We're going to, if we need to get rid of some hair around the area, we're going to clip the hair. Don't shave it, clip it, because remember, shaving is an infection control issue. You could nick the skin. Even microscopic breaks in the skin can lead to infection. So we want to make sure our skin is clean, and we use whatever we need to, usually just a soap and water solution to make sure that skin is clean. Of course, wear your gloves, and then right before you stick, we're going to prep that skin with 70% alcohol or chlorhexidine, whatever your facility requires. Midline catheters. I said these are a little bit longer, and they are. They're usually 3 to 8 inches long, and they come in 3 to 5 French. And you can get them as a double lumen or a single lumen catheter, which is very nice if you need if the patient is a hard stick and you need more than one line going. They're usually inserted through a vein in the upper arm, usually those same veins that are used for PICC lines, and they're used for therapies that last longer than 1 to 4 weeks normally. Don't use these for vesicant drugs though, because they can cause tissue damage if extra vasation occurs. And you know what that is, right? It leaks out into the tissue. And there are different drugs that are vesicants that can really harm the tissue. So that these aren't central lines. Sometimes we think about them as a central line because they have 2 lumens a lot of times, but they aren't central lines, so don't forget, they're not. And they're not to be used to draw blood because, again, they are not central lines. They are just a longer peripheral catheter. All right, central lines, vascular access devices that are placed in the central circulation. All right, that means they go into a big vessel, specifically within the superior vena cava, near the cavo-atrial junction in the right atrium. So basically, a central line, when it's inserted, should rest right before you go into the right atrium. Okay, and central lines have to have a chest x-ray for confirmation before you use it. Exclamation point, before you use it. All right, PICC lines. Again, these are central lines, and I liked this picture here. It gives, so it kind of shows you where a central line should end, okay? So see where it goes into the, up here at the very top of the heart, you've got the superior vena cava, and then the end of that catheter is right there before you go into the right atrium. PICC line length is usually 18 to 29 inches. You always have to get a chest x-ray for a central line, and a PICC line is a central line. So if you need a injection of contrast that's called a power ICC, you have to have a central line because the force that it takes to inject that contrast will rupture a regular peripheral catheter, or it will rupture the vein because you're pushing it in so fast. So if you have one of those power injectables that you need to do for contrast, you really need a central line. And for any kind of central line, you can also attach a transducer for central venous pressure monitoring, which is very helpful, especially in the ICU. Non-tunneled percutaneous central venous catheters. These are inserted through the subclavian vein in the upper chest or in jugular veins in the neck. If you can't get them in either of those, it may require insertion in the femoral vein. But just remember, anytime you have a catheter of any type in a major wet area like the groin, your rate of infection is going to be really high. So if you can possibly have a central catheter in any other vein besides that groin, it would be better. Non-tunnel percutaneous central venous catheters are 7 to 10 inches long, and you can see right up there in the subclavian vein how it wouldn't have to be that long to be able to get to right above the right atrium. And also just note that the femoral vein, it is really huge, but that catheter does not reach all the way to the right before the right atrium if you put it in the femoral vein. But it is still considered a venous catheter because it will go, a central catheter because it will go into your central circulation, which would be your not your superior vena cava, but your inferior vena cava. Okay. So The tip usually resides in the superior vena cava if you do a subclavian, and of course chest x-ray always confirms placement. So most central lines are going to be in the superior or inferior vena cava, and if they're in the superior vena cava, we're going to make sure they're as close to the entrance to the right atrium as we can get. So tunneled central venous catheters just means that a portion of it lies in the subcutaneous tunnel, okay? These are used for frequent and long-term infusions. They're just more stable than other type catheters. And a lot of times these will have a little cuff of antibiotic containing material to help reduce infection. And see this one, see how it lies there right before you go into the right atrium? It's the central venous catheter. An implanted port. This has a little portal body and a deep septum over a reservoir and a catheter. They can be single or double lumen, and this, to be able to have a port, you do have to have a surgical intervention. So in the surgery, they create a little pocket in the chest that houses the port body, and it's not, usually it's not visible. The port is not visible externally. With a port, you have to make sure you flush it after each use, and if you're not using that port, it has to be flushed at least once a month between therapies to prevent any kind of clot formation in the internal chamber. And just a word to the wise, all central lines need to be flushed before and after you put anything into them. If you don't flush those central lines like you're supposed to, it won't be functional for very long. All right, a dual lumen implanted port in a non-coring needle. Okay, so these are your ports, and see that Huber needle there? That's what you're going to use to access it through the skin. And you can see those little palpation points it has on the hub that's under the skin. That's how you feel and decide where you're going to stick with that Huber needle, okay? And see, it's got a catheter, but the catheter is all the way under the skin before it goes into the blood vessel. So hemodialysis catheters, these are really large lumen catheters, and they are made for dialysis or pheresis. That's where you harvest specific blood cells, okay? So catheter-related bloodstream infections can be a major problem in hemodialysis catheters and also on central lines. There can be vein thrombosis. That's a common problem in a hemodialysis catheter. So what would be important to do? Flush that catheter, right? Don't use these dialysis catheters for administering any kind of fluid or medication unless it's an emergency, and then you can use them. So our infusion systems, you're going to have either a plastic or a glass container, and your plastic will be PVC free or DEHP free. And administration sets, you're going to have a primary set or a secondary set for intermittent administration of medications. There's always add-on systems that you can use, like a little J-loop to extend your tubing. A lot of these now have needleless connection devices, which is just exactly what we need to keep from sticking ourselves. And you can have rate controlling infusion devices, which just means it is some tubing that actually has a rate control dial on the tubing, so that you don't have to have a pump to use it. So just remember that the use of IV pumps does not decrease the nurse's responsibility to carefully monitor the patient's infusion rate and site. So let's say that you have a 200 milliliter bag of whatever, and you have set that to run at 100 milliliters an hour. That means it should run over 2 hours, right? If you go in there, you should be checking how much is running in. Is it running in at the correct rate? I have had an IV pump fail before, and thank goodness it didn't give too much fluids. Instead, it gave too little. So I was giving a fluid bolus, quote unquote fluid bolus, and instead of 500 milliliters going in over 30 minutes, only 150 went in. But it would have been a big problem if I hadn't noticed that. Do you think the doctor would have accepted the fact that his patient didn't get this bolus to help the blood pressure because of a device failure? And I was not paying attention to how much fluid was in the bag? That's not acceptable. So we have to carefully monitor those infusion rates and make sure that the amount is going in that's supposed to go in, and those sites should be monitored very carefully. There's not any reason every time you walk in that room you can't take a peek at their IV site. There's no reason whatsoever that you can't do that. So remember that when you have lipids running in, those tubings have to be changed every 24 hours. So your tubings need to be dated. And I have found with any tubing that needs to be dated that if you will take a Sharpie marker and write it on the drip chamber of the tubing, that's a best practice. That way, it will always be known if the tubing was changed or not. If you're just documenting it, somebody could do a little pencil therapy and not actually change the tubing. But if it's written on that drip chamber, then you'll know if it's been changed, okay? Blood tubing has to be changed within 4 hours. So you need to check your facility's protocol for possible deviations. Maybe they'll say 2 hours, or 1 blood transfusion per tubing. So make sure that you know your facility's protocol, but you do not want to use that tubing after 4 hours regardless of the protocol because it's unsafe for the patient. So what can be some problems locally of IV therapy? Of course, you can always have infiltration, phlebitis, and post-infusion phlebitis. What are some meds that can cause phlebitis? Well, it seems like we're talking about potassium a lot. That's one. Thrombosis. You can have thrombosis or thrombophlebitis. Ecchymosis and hematoma, which is bruising and blood under the skin. You can get an infection at the site, and you can also have venous spasms, which can cause that the vessel will spasm. You've got fluids that are trying to go in, but the vessel is spasmed, so they will actually cause the vessel to burst above that spasm, and then whatever medication you were giving can seep into the skin. And there's always a possibility that you can damage a nerve just by inserting an IV. So be careful and pay attention to your patients and make sure that you listen to them. If inserting this IV is causing a electrical shock to run up their arm, you're on a nerve. You're going to have to pull it out and go somewhere else. And don't be afraid to do that. And you can tell the patient, I'm so sorry, this is on a nerve. You can't see nerves from the outside of the body, but I definitely don't want to injure your nerve, so we're going to have to stick it in another spot. What can be some systemic complications of IV therapy? What about circulatory overload? We've talked about that a bit. If you're giving IV therapies, you need to be monitoring for circulatory overload. And what would that look like? It would look like bounding pulses, big bulging veins in the throat area. You're going to be looking for those venous distension there. You're going to be looking for crackles in the lungs, maybe some pitting edema, okay? Speed shock. That just means you're giving the fluids too quickly. Allergic reactions, you can have that. What about catheter embolisms? So what does that mean? It means that the end of the catheter broke off and is floating around in the body and blocking stuff, okay? And this can happen. Whenever you pull any type of catheter out of the body, you need to look at that tip and make sure that it is intact. So remember, there are interventions to reduce infection. Any kind of needleless system connection, you need to be wiping that for 30 seconds before you access it. So think about that. Do you do that normally? I've seen many nurses go in there and do a quick swipe of that IV hub and then just flush it or do whatever they've got to do with it. You should be wiping that needleless system connection for 30 seconds. Now, when might be an exception to that? Emergency medications, right? Okay. Don't tape connections between tubing sets. Use evidence-based hand hygiene guidelines for CDC and OSHA. So back to that, don't tape connections. Why? Because bacteria can grow in those taped areas. So you don't want to tape those connections between tubing sets. Compartment syndrome. This is when you have increased tissue perfusion in a confined space and it causes decreased blood flow to the area. Older adults, what kind of things do we need to think about with the older adults? Always skincare, right? We need to think about the vein and catheter selection. So you're going to look at their skin. Is it droopy? Is it drapey? Is it going to move when they turn? You need to make sure you select a vein that's in a position that's the most stable you can get for an elderly person. And we're always going to monitor their cardiac and renal changes when we're giving any kind of fluids. So what are some alternate sites? What are some different sites for infusions? You can give intra-arterial therapy, but this is very rarely used. You've got to remember that the arteries run away from the heart. So let's consider the artery in our arm. If you put a catheter in that artery to infuse, let's say, normal saline, where is that normal saline going? Is it going back up into the body? No, it's not. It's going, the blood flow is away from the heart, so it's going down to the hand. It has to go through the capillaries and then come back up to get into the venous system. So with intra-arterial therapy, you've got to be really careful about what you're giving, how much you're giving, and really monitor the pulses distally from the insertion site. Okay. You can give intraperitoneal infusions, and I've seen this done before to kind of do a washing in the peritoneal area. You can also do peritoneal dialysis in this way. You can give subcutaneous infusions. I've never actually seen one of those, but we talked about that a few minutes ago. Intraspinal infusions, and those are usually for pain control. And then you have intraosseous therapy. That is therapy directly into the bone, and normally this is only done if you cannot get venous access in an emergency situation. And then sometimes when I was working in ICU, they would bring me a patient that had coded in the emergency room and they had done an IO or an intraosseous IV. And my goal was to just as quickly as I possibly could, get some other type of IV access so that I could take that intraosseous device out. You don't want to leave those in for very long because they're a route of infection straight to the bone. Osteomyelitis can be a problem with intraosseous therapy, and also bone fracture when you're putting that in. But other than that, there aren't a whole lot of contraindications, but you don't want to leave it in any longer than you possibly have to. Need to get those intraosseous IVs out of there as soon as you can get vascular access somewhere else. As always, you need to be answering the questions that are on each slide in this production. Other than that, there's no assignment for this video because we'll be doing a lot on our days in class and lab to talk about infusions and that kind of thing. So answer all your questions and then you'll be finished.